I'm Jennifer Brown from the Dana-Farber Cancer Institute, where I'm director of the CLL Center and the Worthington and Margaret Collette Professor of Medicine in the field of hematologic oncology at Harvard Medical School. And my specialty is CLL. This year has seen a lot of interesting advances in CLL. In fact, just end of December last year, we had the first approval of a non-covalent BTK inhibitor. Everyone is probably aware that the covalent BTK inhibitors, ibrutinib, acalabrutinib, and zanubrutinib, have really transformed the face of CLL therapy. But resistance is a problem, and resistance is often on target, affecting the C481S residue, or the C481 residue becomes C481S. That abrogates the covalent binding of the covalent inhibitors. So pirtobrutinib is the first-in-class non-covalent inhibitor, which we've heard a lot about the last few years, and it did receive a FDA approval in December for CLL patients who had had prior BTK inhibitor and prior venetoclax. So that adds a whole new line of therapy, essentially, for our patients and enables them to stay in class with BTK inhibitors. Then at EHA, we had the two most convincing presentations for the next potential line of therapy with BTK inhibition, which are the BTK degraders. Now, these work also, in theory, independent of the mutations that we've seen with covalent and non-covalent drugs by degrading the protein. And so two different presentations suggested that the response rate in heavily pretreated CLL patients is on the order of 65% or so. Follow-up's still very short, but this is also very encouraging for another potential line of therapy and probably the most exciting new drugs in CLL at the moment. Well, we've already spared a lot of patients from transplant, although in the last few years we've had a few more coming back around because people have gone through covalent BTK and venetoclax. Now competing with transplant, of course, is CAR-T, which got approved for CLL earlier this year. It's certainly not a home run in CLL. It doesn't work as well in CLL as it does, say, in other lymphomas so far. The people who get the greatest benefit are those who achieve a complete remission, which is only about 20% of the patients. And we don't yet know how to predict who those patients will be. Although actually at this SOHO meeting, we're going to hear some data from Bill Weirda about predictors of outcome with liso-cel.